My name is Dr. Dom. I'm from Vietnam, and today my topic is mini invasive treatment in the supine PCNL. In this topic, I will show you how I involve my PCNL, how I improve my skill, and the step in the PCNL to make my PCNL more safety, less complication, and the patient happy after PCNL. So head noting to the closer. So as you all know that PCNL has a main role for the stone treatment. For you see in the EU guideline, any side of the stone has the role of PCNL. Even any of the position of the stone, we have some kind of role of PCNL. But the main problems to spreading the PCNL is about the complications from the multi-center studies. The complication rate of PCNL is around 20%, and even the patient go to death after PCNL. This is a very scary procedure. And there's many risk factors of the PCNL complications, and about the skill, about the complications, even about the patient. But one of the risk factors to lead to the complication is the size of the tract. As you all know that the more tract size, the more transfusion rate it is. That's why today there's the trend to reducing the size of the tract from the standard one to mini one. Of course, there are a lot of advantages when you downsize the tract. That means you less blood loss and the patient can go home weekly. But there's some of disadvantages. You must trade off when you decide to use the mini tract. That means you must face off with the high intrarenal pressure, and sometimes this makes your operation is longer time. So today nowadays there's a lot of a term of the PCNL procedures, from standard, mini, super mini, and from India we have the ultra mini from Dr. Zanek design, and micro minis from another design. So, and as we know that we have Dr. Stefan Lemmer from Germany. We and Dr. Udo Nakili introduced the term mini PCNL on 2001 with a track about 1615 French. And from the actually when Dr. Udo Nagili introduced the term mini PCNL, it doesn't mean that it's downside of the track. It means you must choose the good one for the patient, the good procedure that only minimize the intervention, that make the good outcome and shorter operation time. It doesn't mean that you must downside the track. It's many things after that must consider. That's in my experience, my point of view, that mini invasive treatment in PCNL, it doesn't mean that you choose a small tract. But there's a lot of things you must consider. That means you must individual treatment to the tract for the patient. You must do the PCNL less complication, and you must shorten the operation time with the same efficacy. And of course, you must make the patient happy, make the patient less painful after PCNL. That is the meaning of the mini invasive treatment. And the first is the individual treatment. You know that patient have the different body type, and of course the different of the calicio anatomy different, and even the shape of the calicio is also different. That's been my experience when I introduced the mini invasive for the patient. I use the term the Bespoke approach. That's mean I tailor the instrument to the patient, not vice versa, because you all know that the best glove is the glove fit to you, and the best instrument that is the instrument fit to the patients. That's why I always tailor choose the fit track to the patient. So what is the Bespoke approach? This is the term of my term. That means I use the track fit to the patient calyceal anatomy. That means the size of the tract must fit to the width of the callus, because you know if the size of the tract is too big, it's more laceration and more bleeding. But the size of the tract is too small, it makes your operation time is longer, and sometimes it causes infection. That's why when I was choosing between mini and conventional tract for PCNL, I always check the retrograde biography to check the width of the callus and to decide the instrument appropriate to the width of the callus. So if I see that the callus has a very long, narrow callus, like these pictures, I will choose with a mini approach, 16 French Amplatz with the 12 French scope. And this picture, if I see that this is a very wide callus, I will go with the conventional approach with a 24 French Amplatz and 24 French nephoscope. So how to, and the second to the mini invasive is to preventing the high intrarenal pressure. This is a very old study about the biliovenous backflow. As you know that if the pressure above the 30 millimeter mercury, it leads to the biliovenous backflow and it causes septic after PCNL. That's why doing the PCNL in the low pressure is mandatory to preventing the infections. So you know that in the PCNL, the inflow and the outflow system, we have the two systems. First is the closed system, and the second is open system. The closed system, that means that the outflow is blocked, and sometimes it's not a continuous outflow. And the open system, that means the outflow is continuous. And you know, if you use the closed system, you see that in the intrarenal pressure, every step is above 30 millimeters of mercury. Otherwise, if you use the open system, the intrarenal pressure is always go lower than the 30 mercuries. That's why on my case, I do PCNL, I always use the open system to prevent high intrarenal pressure. If you see in these pictures, even you use with the very small tract, mini tract, but if you use the open system, the intrarenal pressure is the same with standard tract, but it is very slightly higher if you use RRS or microbird. If you use the closed system, the intrarenal pressure is higher. And from the textbook, the Smith textbook of Urology, to prevent the complete infection after PCNL, you must use the 4-frame difference between the tract and the scope. That means if you choose your tract is 24, your scope must be 20. And if you go with mini about 16 frames, you must choose the scope is around 12 frames. It must be at least 4-frame difference to make the low intrarenal pressure during your procedure. And I want to shorten my operation time even when I do PCNL. There's some points when I shorten my operation time in PCNL. The first, I change to supine position, and then I use the step dilator or one-shot dilation. And otherwise, I use the vacuum cleaner effect or vortex effect to clear out the stones. So I changed my position from prone to supine 3 years ago. I started PCNL from prone position, and after that, after 2017, I do all my case in the supine positions. I never go back to prone anymore. And of course, when you do supine PCNL, you shorten the time of the operation time because you don't need to change in the patient position when after you put in the retrograde biography. You don't need to change in patient position. And you know, my position in supine PCNL, I set up patient position very simple, and I use the instruments available over the world. Just put the 2 bottles of natrium chloride, one to the patient back and one to the patient in the patient crucial region to make the space between it free. So very easy, and I can set up my patient position only by myself. This video clip I set up by patient position only by myself without any assistant. I just put the one portal to the patient pack. And then put one portal into patient gluteal region. And then that's finished. It's very simple, and I can do it by myself. And less than 1 minute, I can finish it. And I changed to one shot or state dilation because I think that one shot is very faster and less X-ray exposure for the doctor and for the patient. I always use a one shot or Amplatz state dilator with a guide wire catheter put inside and then sitting and 24 Amplatz dilator. In the case had the previous scar or the flank is so sticky, I will back up with the NK metallic dilator just in case difficult when I fail with the Amplatz dilator. This is the video clip. I show you how I do the Amplatz stack dilator. So after I enter the callus, I put the guide wire go into the collagen system. I open the skin and then 8 French fasta dilator, always under the control of CM. And then I insert the coaxial dilator, or you can use the ureteral catheter. And after this, I use the 16 French Amplatz dilator. Always under the CM. And then 24. So I think when I do the state dilator, the duration time is shorter and less X-ray exposure. So the state later is introduced in 2001, and for the meta-analysis systematic review about the 4 different tract dilators, the state later is safe and efficacy. It makes your operation time is shorter and less fluoroscopy time. And for remove the stone, even for make the high stone free rate, I use the vacuum cleaner effect. I just moved the track near to the stone and slowly remove the scope, and the stone will go to the scope and go out by gravity. In the bronze and supine, the vacuum cleaner effect can happen, but in the supine PCNL, the vacuum cleaner is more effective and more higher than in the bronze position. Because in supine position, your track is slightly going down, and you just put the nervous, the Amplatz track near the stone and remove the scope, and the stone can go out by gravity. Vacuum cleaner effect is make your operation time is shorter because you don't need many steps to remove the stone when you fragmentation. And for make the patient recover quickly, I usually use the very before I finish the PCNL. For existing surgery, I use very small tube. Even I use standard one 24 French dilatation, but I use a very small tube because I think that the tube cannot terminate the bleeding or terminate anything. It's just for you for monitor the patient and for RENET to prevent the infections. And when the case with the simple case and uncomplicated cases, I usually tubeless for the patient because the tubeless make the patient less painful and patient can go home earlier. So this is the tube I use. I never inflate the balloons. I just use the small tube available in my OR. And for the case uncomplicated case, I use the tubeless. treatment. That means you must do the tract for the patient, not vice versa. And you must do the PCNL in a very enough intrarenal pressure. And shorter operation time with Supine PCNL, higher stone fill rates with vacuum cleaner effect, and you can make less X-ray exposure and shorter the time of dilatation with stage or one shot dilation, and shorter the hospital stays with the small tube or tubeless PCNL. And thank you. Thank you. This is answer my slide.